She had just given birth to a healthy baby girl. 23 years old, first-time mom, beautiful delivery, no complications during labor. Baby was perfect, 8 pounds, 2 ounces, crying, pink, healthy. And the mom? She was smiling, talking to her family, holding her baby, asking for water. Her blood pressure was 110/70. Heart rate was 98. Oxygen saturation 99% on room air. Everyone said she looked great, but I knew she was bleeding to death.
That's the terrifying thing about postpartum hemorrhage. It hides in plain sight. The vitals say stable, while the patient is actively dying.
And this was maybe 4 years into my nursing career. I was working in high-risk OB, and I had just started to understand what compensation actually looks like. See, here's what I saw. Her skin was pale. Not just gave birth pale, pale, like all the color had drained from her face. Her lips were white. She was asking for water every 2 minutes, not casually, urgently. Can I have more water? I'm so thirsty. And that heart rate, 98, doesn't sound high. It's technically within normal limits. But 30 minutes ago, during recovery, it was 72.
A 26-beat jump in 30 minutes. That's the body working harder and harder to maintain perfusion. Classic early compensation that gets missed because everyone's staring at the monitor saying, 98 is normal.
Exactly. Nobody else was paying attention to the trend. They were just looking at the number, but her body was screaming at me. I checked her pad, soaked. I did a fundal assessment. Her uterus was boggy, not contracted like it should be. I looked at the monitor one more time. Blood pressure still 110/70. Heart rate now 102. And I remember thinking, she's compensating. And when she stops compensating, she's going to crash hard. I called the charge nurse. I said, I think she's hemorrhaging. I need the OB here now. And the charge nurse looked at the monitor and said, her vitals are stable. What are you worried about?
That's the response that gets people killed. The monitor says normal, so everything's fine. Meanwhile, the patient is using every ounce of physiological reserve to keep that blood pressure up.
And I said, I don't care what the monitor says. Look at her. She's pale, tachycardic, and thirsty. She's losing blood faster than her body can keep up. The OB came, did a quick assessment, looked at me and said, good catch, get the hemorrhage cart. We did a manual uterine massage, started Pitocin, gave methylargonavine. Her bleeding slowed, but here's the thing. 5 minutes later, her blood pressure dropped to 82/50. Heart rate shot up to 130.
So even with early intervention, she's still decompensated, which tells you how close she was to coding when you first called it.
Exactly. Because by the time the blood pressure drops, the body's already been failing for a while. We were just ahead of it enough to intervene before it became a full code situation. But if I had waited, if I had trusted the normal blood pressure, she could have gone into hemorrhagic shock, could have needed a massive transfusion, could have ended up in the ICU. And that's the case that changed everything for me.
Because you learned that vital signs don't tell you what's happening. They tell you what already happened. By the time the numbers look bad, you're already in crisis mode.
The body lies, vital signs lag. And if you wait for the textbook signs, you've already lost. And that's what this episode is about. Welcome to the Think Like a Provider podcast. I'm Jennawè Whitley, nurse practitioner and educator. Here, we don't memorize, we understand. Each episode, we break down clinical reasoning, system by system, so you walk away thinking and acting like the provider you are meant to be.
And I'm Alice, and I'm here to ask all the questions you're probably thinking while you're listening.
So let's break down what actually happened in that room, because this isn't just about postpartum hemorrhage. This is about understanding how the body compensates, and why waiting for abnormal vitals is waiting too long.
And it's universal. Whether it's postpartum bleeding, a GI bleed, trauma, post-surgical hemorrhage, the pattern is the same. Once you learn to see compensation in one context, you can recognize it everywhere.
Exactly. So let's talk about what compensation actually looks like. The problem: why students miss early hemorrhage. Here's what happens when you're a nursing student learning about shock. You learn the stages: compensated shock, decompensated shock, irreversible shock. You learn the classic signs: hypotension, tachycardia, altered mental status, decreased urine output. You learn that blood pressure drops in hypovolemic shock.
And then you walk into a patient's room, see a blood pressure of 110/70, and your brain says, normal equals stable. You've been conditioned to trust the numbers over your clinical instinct.
Exactly. And that's the problem, because here's what nursing school doesn't teach you. Blood pressure is the last thing to drop. Let me explain what actually happens when someone starts bleeding. Let's say this patient is losing blood. Maybe she's bleeding from the uterus, or there's a laceration, or her uterus isn't contracting properly, and she's just slowly oozing. Her body immediately recognizes, we're losing volume. We need to protect the vital organs. So what does it do? First, it increases the heart rate. More beats per minute means more blood flow to the brain, heart, and kidneys, even with less total volume. Second, it constricts the blood vessels in the periphery. The body says, we don't need blood flow to the skin and extremities right now. We need it in the core. So the patient gets pale, cold extremities, delayed capillary refill. Third, it triggers the kidneys to hold on to water. The body says, we need to maintain blood volume. Stop peeing. So the patient gets thirsty, really thirsty, because the kidneys are conserving fluid and the body wants more intake.
So by the time you're seeing tachycardia, pale skin, and thirst, the body's already in crisis mode. It's just hiding it really well. Those aren't early warning signs, they're active compensation.
Exactly. These are the body's emergency mechanisms kicking in. And here's the thing. A young, healthy person can lose 30 to 40% of their blood volume before their blood pressure starts to drop.
That's over a litre of blood. So this patient could be sitting there talking, looking fine on the monitor, and she's already lost more blood than fits in a large water bottle. No wonder students miss it.
That's compensation. The body is incredible at hiding failure until it's not. The shift. Learning to see compensation. So let's go back to that patient. Let me walk you through what I was actually seeing versus what the monitor was showing. What the monitor showed, blood pressure 110/70, normal. Heart rate 98, normal. Oxygen saturation 99%, normal. What I saw, skin, pale, almost white. Lips, colorless. Capillary refill, sluggish, maybe 3 to 4 seconds. Behavior, restless, repeatedly asking for water. Fundus, boggy, not firm. Pad, soaked through in less than 15 minutes.
This is the disconnect between data and clinical reality. The monitor is giving you lagging indicators, what the body managed to maintain despite what's going wrong. But the patient assessment is giving you real-time information about what's actually happening.
Exactly. A student sees the monitor and thinks, vitals are normal, patient is stable. A provider sees the patient and thinks, this doesn't look right, something's wrong. Now, here's the framework I use to differentiate normal postpartum recovery from early hemorrhage. Normal postpartum recovery looks like tired but alert, pink or slightly flushed. Heart rate may be slightly elevated, 70s to 80s, but stable. Asking for water but not desperate. Uterus firm, pad with moderate lochia. Early hemorrhage looks like restless or anxious. The body knows something's wrong. Pale, cool skin. Heart rate climbing, 72 to 85 to 98 to 105. Repeatedly asking for water, can't get enough. Boggy uterus, soaked pads, pooling blood.
So it's pattern recognition across multiple data points. You're not looking at one vital sign or one assessment finding. You're looking at how everything fits together into a clinical picture. And when those pieces don't match normal recovery, that's your red flag.
Exactly. And it's a trend, not a snapshot. That heart rate didn't start at 98. It started at 72 and climbed over 30 minutes. That's compensation. The body is working harder and harder to maintain blood pressure. And students miss the trend because they're taught to document vital signs at specific intervals, not to track the trajectory. They chart HR 98 without realizing it was 72 an hour ago, which is why you have to think in trends. What was it before? Where is it going? How fast is it changing? Because when compensation fails, it fails fast. The crash, decompensation. So we intervened. We massaged the uterus, started medications to help it contract, slowed the bleeding, but 5 minutes later the monitor alarmed. Blood pressure 82/50, heart rate 130.
That's the cliff edge of compensation. The body held on as long as it could, but once it runs out of reserve, the crash is sudden and dramatic. This is why early intervention matters. You're trying to stop the bleeding before the patient falls off that cliff.
Exactly. And here's the difference. We were ready. We already had IV access. We already had the hemorrhage protocol started. We were already transfusing. If we had waited until the blood pressure dropped to start intervention, we would have been 10 to 15 minutes behind. Once blood pressure drops in hemorrhagic shock, you're in a race. You're trying to replace volume faster than they're losing it. You're trying to get the bleeding under control before they code. And in a postpartum hemorrhage, minutes matter.
So catching compensation didn't prevent decompensation, but it gave you the time and resources to stay ahead of it. Instead of reacting to a crisis, you were already managing one.
Exactly. We got the bleeding under control. She needed 2 units of blood. Her hemoglobin dropped to 6.8. But she was okay. She went home with her baby 3 days later. But I think about that case all the time, because if I had trusted the monitor instead of my eyes, that story could have ended very differently. Why this is so hard?
I think the hard part for students is that we're trained to be objective. Subjective feelings don't count. Show me the data. But this case is literally about trusting what you see over what the numbers say. That's a complete mindset shift.
And that's exactly why this is so hard. Because your brain wants the monitor to tell you the truth. Your brain wants clear, objective data. Your brain wants the algorithm. If blood pressure is X, then do Y. But the human body doesn't follow algorithms. Let me give you a framework for how this plays out in real time. You walk into a room. Before you even look at the monitor, what do you see? Patient's color, pink, pale, gray. Work of breathing, easy, labored. Mental status, alert, confused, anxious. Skin, warm, cool, diaphoretic. Then you look at the monitor and you ask, does this match what I'm seeing?
So you're using the monitor to confirm or question your clinical assessment, not as the primary source of truth. The patient is the truth, and the monitor is just one piece of supporting data.
Exactly. The monitor is data, but the patient is the truth. Now here's where students get stuck. What if you escalate and the provider thinks you're overreacting?
That's the fear, right? I called a rapid response and the patient was fine. Now everyone thinks I panicked over nothing. That fear of looking incompetent keeps students from speaking up when something feels wrong.
And I'm going to tell you the same thing I tell all my students. I would rather call for help and be wrong than not call for help and be right. Because here's the thing, I can handle someone thinking I overreacted. I cannot handle watching a patient die because I waited too long.
And honestly, the providers who judge you for advocating for your patient aren't the ones you want to learn from anyway. The good ones will teach you what you missed or confirm you made the right call.
Exactly. That's a provider mindset. You advocate for the patient even when the numbers don't back you up yet. How to recognize compensation, a practical framework. So let me give you the framework I use now. This works for any kind of shock, not just hemorrhage. Step 1, look at the patient first. Before you look at the monitor, do a visual assessment. Skin color and temperature, work of breathing, mental status, overall appearance. Ask yourself, does this patient look sick? Step 2, check for early compensation signs. These show up before vital signs change. Tachycardia or heart rate trending up. Tachypnea or respiratory rate trending up. Pale, cool skin. Delayed capillary refill, greater than 2 seconds. Thirst or dry mucous membranes, restlessness or anxiety, decreased urine output,
These are all sympathetic nervous system responses. The body is in fight or flight mode, diverting resources to vital organs. So, if you see multiple signs from this list clustering together, that's not anxiety or dehydration, that's the body compensating for something serious.
Exactly. Step 3. Look at trends, not numbers. Don't just ask, what is the blood pressure? Ask, what was it 30 minutes ago? Is it trending up or down? Is the heart rate climbing to maintain it?
This is where electronic charting actually helps, if you use it right. Pull up the flow sheet, look at the vitals over the past 2 to 4 hours, and see if there's a pattern emerging. A blood pressure that's been 120 over 75, 118 over 72, 115 over 70, 112 over 68. That's a trend toward instability, even though every individual reading looks fine.
Yes. And then you ask yourself the critical question. Step 4. Is this patient working too hard to look okay? If yes, they're compensating, and compensation doesn't last forever.
That's the key question that shifts you from reactive to proactive. You're not waiting for the patient to crash. You're recognizing that they're already in trouble. They're just hiding it well.
Exactly. The goal is to catch them while the body is still fighting, because once the body gives up, you're in trouble. Applying this beyond OB.
So this postpartum hemorrhage case is the teaching example, but the compensation pattern applies to any patient losing volume or perfusion. GI bleeds, trauma, post-surgical bleeding, even distributive shock like sepsis, they all follow the same physiological pathway.
Exactly. The body has a limited number of ways it can fail, and once you recognize the pattern of compensation, you can apply it anywhere. Let me give you an example. You're working med-surg, you have a patient 2 days post-op from a bowel resection. You walk in for your assessment. He's sitting up in bed, watching TV. Vitals on the monitor. Blood pressure 118 over 72. Heart rate 92. Respiratory rate 18. And SpO2 97%. Looks fine, right? But you notice his skin is pale. He's sweating a little. And when you ask how he's feeling, he says, I'm fine, just really thirsty. You check his abdomen. It's firm, distended, more than it was this morning.
Internal bleeding. Same pattern as the postpartum patient. Pale, diaphoretic, thirsty, tachycardia, plus the physical finding of abdominal distension. The mechanism is different, but the body's response is identical.
Exactly. You don't know for sure yet, but you recognize the pattern. So what do? You call the provider. Hey, I'm concerned about possible internal bleeding. Vitals are currently stable, but he's showing early signs of compensation. Can you come assess? Maybe you're wrong. Maybe it's nothing. But maybe you just caught a post-op bleed before he went into shock.
And this is why clinical reasoning beats protocols. A protocol would say, notify provider if BP drops below X or heart rate rises above Y. But by then, the patient's already crashing. Clinical reasoning says, these findings don't fit the expected recovery pattern. I need to escalate now.
Exactly. The pattern is the same, even though the cause is different. Hemorrhagic shock looks like hemorrhagic shock, whether it's postpartum, post-surgical, or traumatic. And once you learn to see it, you can't unsee it. Here's what I want you to take away from this episode. Your patient's body will tell you the truth, but you have to know how to listen. Vital signs don't tell you what's happening. They tell you what already happened. By the time the numbers look bad, you're already in crisis mode.
So the skill is recognizing compensation before decompensation. Look for the early signs: tachycardia, pale skin, thirst, anxiety, and pay attention to trends, not snapshots.
Exactly, because a young, healthy person can maintain a normal blood pressure while losing liters of blood. And if you wait for hypotension to act, you've waited too long. And this pattern applies to all types of shock: hemorrhagic, septic, cardiogenic, anaphylactic. The body compensates the same way. Learn the pattern once and you can recognize it everywhere. But here's the hard part. You can't learn this from a textbook. You can't learn it from memorizing the stages of shock. You have to practice seeing it. You have to work through cases. You have to ask yourself, What am I seeing? What does this mean? What could go wrong?
And that takes deliberate practice, not just passive studying.
Exactly. And that's why I created Think Like a Nurse and Think Like a Provider. These are clinical reasoning systems designed specifically to help LPN, RN, and NP students develop the necessary skills to excel in clinicals and at the bedside. Not just memorization, actual clinical reasoning, the kind of thinking that catches patients before they crash. You can find the link in the show notes. And if you're looking for community, a place where you can practice this kind of thinking with other nursing students who are serious about becoming excellent clinicians, be on the lookout for the Think Like a Provider School community. It's a community that's going to change the way you think, understand, and do nursing. We work through real cases together. We practice clinical reasoning. We support each other through the hard parts of this journey. The link to join the waitlist is in the show notes as well. But for now, I want you to do this. The next time you're in clinical, don't just look at the monitor. Look at the patient. Ask yourself, does this patient look like they're working too hard to stay stable? Because if the answer is yes, they're compensating.
And compensation doesn't last forever. Trust what you see, not just what the numbers say.
Thanks for listening. I'll see you next week.
See you next week.